kava is the sinoatrial node. To make it short, SA node. It's the normal pacemaker because of its self-excitation. It's the fastest rate of discharge, about, in the book it says 80 to 70 to 80, but let's make it 60 to 100 because the sinus rhythm is 60 to 100. And so because of that firing rate, 60 to 100, it dictates the heart rate. Kaya siya yung normal pacemaker. So take note that the conducting system of the heart is autonomous. Parang autonomous region. Ano bang term yan sa Mindanao? It's autonomous. It's not, it has its own capacity to decide. Parang continuous lang siya without the need of information coming from the central nervous system. So the CNS, or via the sympathetic nervous system, can affect the beating of the heart by increasing it or decreasing it. But the heart can actually try to not accept that. Parang ganon. However, kaya nga siya, yung special conducting system of the heart is autonomous. Okay? Kaya tama yung sinasabing follow your heart, no? Or the heart has its own mind. Parang iba yung tingin mo dapat mahalin, pero yung puso mo iba yung minamahal. Tama pala yun. It makes sense. So the specialized conducting system of the heart is autonomous, and that the SA node is the normal pacemaker. So this, once the SA node is activated, the electrical impulse will travel so fast into the AV node. And later, I will show you kung ilang seconds dumadating yung electrical impulse. So ipapasa niya to AV node. And in the AV node, it has this lowest conducting velocity because the anatomy of the AV node has diminished gap junction, so the spread is so slow. But actually it has benefit to that because it will delay transmission of the impulse from the atria to the ventricles. Kasi gusto mo ma-complete yung relaxation ng atrium para to fill in blood. And then you want the ventricles to complete its contraction, no? And then by the time that during diastole, when the atrium contracts, diba, nag-fire na yung SA node, after that both the atrium are depolarized. And then you want the ventricles to completely relax to fill in the blood from the atrium. Kasi kung prematurely naipasa ni AV node to the ventricles yung electrical impulse, so the ventricles, let's say half fill the blood, and then nag-contract siya kaagad. So the stroke volume is decreased. So you want a very good, more time to relax, meaning the ventricles will relax completely to fill in blood so that when it contracts, it will deliver a higher stroke volume. So the purpose of the AV node is to delay transmission of the impulse in between the atrium to the ventricles, and this is to allow more time for the ventricles to fill in blood, okay? And the AV node has a rate of about 40 to 60. So if SA node is 60 to 100, the AV node is about 40 to 60. So kung titingnan nyo, mas mababa yung firing rate ni SA node. And if there's a damage to the SA node, the next pacemaker that will fire is the AV node. Kaya ano siya, slower lang yung rate niya. So after the impulse has arrived to AV node, it will delay for less than 200 milliseconds. And then the impulse will now arrive into the bundle of His. The bundle of His is a structure that has to penetrate the skeleton. Kasi this area here is made up of fibrous skeleton or fibrous material. Di ba? Tricuspid valve, mitral valve, ano naman siya yung mas dense yung structure niya. It's made up of fibrous material. And so it has to penetrate that fibrous skeleton anatomy. And that's the bundle of His. It's firing between 20 to 30, some perhaps na ano. It's slower than the AV node. And so normally the only pathway for SE node impulse to reach the ventricles is through the bundle of His. Okay, and the AV node, it's this area from AV node to bundle of His where the electrical impulse from the atrium can pass through the ventricles. Wala na pong iba. For example, the SE node has spread through the right atrium. Hindi yan makakapasok over here to depolarize this area. At the same time, when the impulse arrived to the left atrium, it cannot, the electrical impulse cannot pass through over this area. So, hindi siya, all the electrical impulse will only pass through this area. And the purpose of that is, gusto natin, isa lang ang mag-stimulate. Anyway, you only need one stimulation and the rest, both the right and the left ventricle will contract together, synchronously because of syncytium, di ba? Ang yung physiology nila. You just need to stimulate one area and then mag-spread na yung electrical impulse. Okay? So the next conducting system of the bundle of His are the bundle branches. We have the left and the right. So the left bundle branch divides into 3, septal branch, and then anterior, and then posterior branch. Tatlo daw yan sila. And then the right branch, isa lang siya. So it will, both the right and the left branch will penetrate this septum and then penetrate the lateral wall. And then after the bundle branches, it will divide into these Purkinje fibers, which is the fastest conducting velocity. So magkaiba ang fastest rate of discharge and fasting conducting velocity, because fastest rate of discharge is like beats per minute. It's 60 to 100 beats per minute. But when we talk about velocity, that's in meters per second. So napakabilis lang ng velocity across the Purkinje fibers. If you are asked what's the fastest conducting velocity among all the conducting system of the heart, the answer is Purkinje fibers. But if we talk about fastest rate of discharge, it's the SE node, and we will talk about why the SE node has the fastest rate of discharge. All right? So you have to memorize this because over the course of the lecture, kailangan memorize nyo SE node, AV node, bundle of His, bundle branches, the right and left, and the Purkinje fibers. So lalabas yan probably sa exam, the fastest rate of discharge is SE node, and that's why it's the normal pacemaker. And lalabas din yan sa exam, the fastest conducting velocity is the Purkinje fibers. Okay? So if you have to appreciate, if you believe in God, parang ang sarap pakinggan nyo, i-realize na if there's damage to the SE node, you have a second pacemaker that will fire para mabuhay ka. Kung damage both the SE node and AV node, you will still be alive because there's a bundle of His firing at a slow rate. Kahit madamage pa yung bundle of His, the Purkinje fibers can still be a pacemaker and fire, let's say 20 to 30 beats per minute. Somehow it will keep you alive. Now the ventricles has no firing, hindi siya pacemaker that will fire. Pwede siya mag-produce ng electrical impulse pero fibrillatory or in a ventricular tachycardia pattern, hindi siya nakakabuhay. Okay? So this is how everything happens. You start from the SE node, and then eventually the electrical impulse will spread both the right and the left atrium. Magkasabay yan. Maybe madidelay lang yung lateral portion ng left atrium, but sobrang bilis lang yan. And take note that this happens on the latter end of diastasis. Huwag ma-confuse. This does not happen on the isovolumic relaxation time or rapid filling time. It's the latter end of diastasis. Magko-contract sa right atrium. So don't be confused. Now, once both the atrium has been depolarized, kasabay din naman na nadidepolarize si atrioventricular AV node. It's just that it delays this electrical impulse. Parang hahawakan niya muna ng less than 200 milliseconds because this is the time that the ventricles are still on diastole. And then by the time, at the end of less than 200 milliseconds, the electrical impulse will now reach to the bundle of His, and then the right and left bundle branches, and then the Purkinje fibers. So it will spread throughout the muscle of the ventricles, and then after the QRS complex is produced, the ventricles will contract. And then after that, the electrical impulse will die down. Then you go into repolarization, producing the T wave. So you cannot see the P wave stands for or reflects the atrial contraction, and there should be atrial relaxation, but it's a small wave and it's embedded behind the QRS. So hindi siya nakikita. The QRS complex kasi is produced by contraction or depolarization, not contraction, but depolarization of the right and left ventricle, which is a big chamber made up of muscles. And that's why it produces this wider complex. Okay? So, nakikita natin yung T wave. Alright. So magtatanong kayo, bakit mas malaki yung T wave versus the P wave? Since depolarization naman si P wave, but repolarization naman si T wave, and that's because ventricular relaxation, since it's ventricles, it's still bigger, it's still a big chamber as compared to atrium, and more muscular, kahit naman relaxation lang siya, it still produces a bigger wave. All right, so we have talked about the action potential, yung may resting membrane or phase 4, phase 0, 1, 2, which is the plateau phase, and then 3, repolarization phase, and back to resting. And that's on other non-pacemaker cells. So wag ma-confuse. The SE node has a different action potential. It's like, ano lang siya, resting, phase 0, and then 3, resting, phase 0, and then 3. So para lang siyang up and down, up and down. So it has a less negative resting potential, negative 55 to negative 60. Kaya mas madali siyang ma-depolarize. Kasi yung membrane potential ng non-pacemakers is more negative, 85 to negative 90 millivolts. And if you look at the resting membrane ng SE node, para siyang gradually increasing. Hindi katulad nito na, alam mo yun, flat na flat talaga siya. And this is because of this leakiness of the sodium and calcium channels. Ano ba yung leakiness na yan? Dito kasi sa non-pacemaker cells, the cell membrane has this fast sodium channels and L-type calcium channels. It's totally closed at resting membrane. Kaya walang pumapasok, walang lumalabas, masyadong strict yung cell membrane. So when there is an action potential, there is that conformational change of these channels na nag-o-open sila. Saka lang papasok yung sodium and calcium channels, saka ka lang nakakakos ng depolarization of this phase 0. Okay? But here, kahit resting membrane potential siya, yung sodium and calcium channel are entering slowly. Parang pumapasok sila. And that's why pataas siya ng pataas, no? Pataas siya ng pataas. And tatanong kayo, Doc, bakit hindi siya agad-agad na lang tumaas? And that's because this is during the resting membrane potential. It's also the time that the potassium are leaking out. So some sodium and calcium, which are positive ions, are going inside the cell to depolarize, to somehow increase the positivity from negative 55 to probably negative 40, parang ganun. So it's also the same time that the potassium is going out. Kaya hindi siya agad-agad pumupunta sa positive or 0 or positive 10, for example. So once this potassium channel closes, that's the time that wala nang lumalabas na positive ions. So dire-diretso na si sodium and calcium pumapasok into the cell, and it will completely depolarize the cell. And so kaya siya tumataas. Okay? And then once the sodium and calcium channel will close, magda-drop yung negativity. It will go to more negative potential ulit. And then the potassium channel will open, and then the sodium channel will open again, But magkaiba lang yung entry lang yung sodium and calcium, exit lang yung potassium. And this is the reason why the SE node is the pacemaker, because it's easily depolarized, and this is the reason why it's self-excitatory. Kasi the sodium and calcium channel and the potassium channel will just open and then close and then open and then close. Kaya nakaka-produce ng wave, and it has a discharge. Usually normal naman yung discharge rate. Let's say ngayon, the SE node is firing at 70 beats per minute. It will be firing at 70 beats per minute if you are resting. But once you start walking or you start traveling or running, then the firing discharge of the SE node will be faster. Let's say 90 to 120 beats per minute. So tatawagin na siyang more than 100 beats per minute. It will be now tachycardia because it's 100 beats per minute, but still sinus because what's firing is still the SE node. So whenever you see a word sinus rhythm, it means to say that it's the SE node firing. Okay. If you don't see a P wave, if the SE node is firing and other pacemaker are firing, we will not call it sinus node. So in the next lectures, you will hear about junctional rhythm or idioventricular rhythm. It means to say it's a slower rate, less than 60 beats per minute, and that there will be no P wave because it's not the P wave. If the SE node is firing, there should be a P wave. If you cannot see a P wave on the ACG, that it's not the SE node firing. Okay, so just to make it clear, the pacemaker cells or the SE node has a negative 55 to negative 60. It has automaticity and rhythmicity, and it's self-excitatory, and this is because of the leakiness to sodium and calcium, and it's the cause of this gradual rise in the resting membrane potential. It does not go up because, or it does not completely depolarize to phase zero. It's because during the resting membrane potential, the potassium is going out of the cell. So parang giniba niya yung memorize natin about this action potential, yung ni-lecture natin last time. So kakaiba yung nangyayari sa SE node. Alright? Hirap nun. Okay. So if you look at this, this is the action potential just to cement what we have lectured last time. Yung action potential. So anyway, na-lecture ko na yan. I just would like to show you that there is this phase zero. So sa resting membrane potential, if you look at the sodium, the rise of the sodium, during resting, halos walang pumapasok na sodium. And then phase zero, sobrang steep, sobrang pasok lahat ng sodium. And then the sodium channel will close. But kaya siya bumababa. And then during the phase 2, meron pa namang konting sodium na pumapasok, kaso lang mababa lang. And that's because we still have these slow sodium channels. So the origin of this rapid rise is because of a fast sodium channels. And then the cause of the sodium channel entering on this phase is these low sodium channels. So if you look at calcium channels during resting membrane potential, halos walang pumapasok. And then the 20% calcium from outside of the cell will enter into the cell, okay? And then during this phase 2, which causes the plateau, some of the calcium channels are exiting in the sarcoplasmic reticulum. So it's providing these calcium channels in the cytoplasm. And that's the cause of this plateau. And then the sarcoplasmic reticulum will stop delivering calcium. And that's why there is that rapid decline of the level of the calcium. So if you look at the potassium, kahit sa resting membrane potential, ano lang siya, flat lang din siya. Pero meron kasi nasa loob siya ng cell. And then it just closes, the phase 1, mag-o-open siya. Bakit naman siya pa-drop? Kasi nga lumalabas siya outside the cell, so nababawasan ng potassium inside the cell. So there's that drop. Even during phase 2, mas lalo pa siyang nagdo-drop, mas malalo pang nag-exit yung potassium. And then during repolarization, pag mag-close na yung, pag mag-close na yung potassium channel, tataas uli yung potassium level. And then when the sodium-potassium ATPase pump will act to bring back the potassium, that's the time that the potassium level will go up again because you increase the level of the potassium inside the cell. And so this is the nature or the picture of the action potential and what's happening between the entry of sodium and calcium and the exit of potassium in a cardiac muscle. And this is different, completely different with what's happening in the SA node. Okay, I hope I just made that clear. Iba din ang shape and what's going on inside an action potential in a smooth muscle. Iba din yun, and I'm not going to discuss that. Dapat na-discuss na yan in the previous lecture. So, what's characteristic for a cardiac muscle is this plateau phase. That's characteristic of a cardiac muscle. You have this plateau phase, and the purpose of that is because you need calcium for contraction. You need ventricular muscles or the myocardial cells to have these strong contractions so that the systole portion will be augmented and you will produce a good stroke volume. Okay, ang hirap na, no? Okay, so ito yung how the electrical conducting system or from the time interval that the electrical impulse arrives to some areas. So start at the SA node. In 0.3 seconds, it will arrive at the AV node. So if you look at the atrium, the septum, at the same time, parang sabay lang nakaka-receive ng electrical impulse. The atrial septum and the AV node receives at the same time the electrical impulse, but it will take about 0.7 to 0.09, not 0.7, sorry, 0.07 to 0.09 for the entire atrium, both the right and left, to be depolarized. So there is that delay, 0.3. From 0.3, there is that delay of electrical impulse. From 0.3 to 0.16, so meron kang delay there na hindi makakapasok yung electrical impulse into the ventricles because it takes 0.16 seconds for the septum to be depolarized. So dun lang dumating yung electrical impulse into the septum. So at 0.16 seconds, the septum of the ventricles, interventricular septum, will be depolarized, and it will spread into the inferior and superior, lateral and superior portion of the ventricle. So I need you to look at these details because the bundle branches are in the septum and in the endocardium, while the Purkinje fibers spreads into the myocardium and epicardium. Kaya if you look at the course of the cardiac impulse, the septum, meaning the interventricular septum, is depolarized first before the lateral wall. Ito, yung lateral wall. So mauuna yung septum versus the lateral wall. And if we dissect into the anatomy of the myocardium, di ba meron tayong endocardium, myocardium, and then epicardium, mauunang ma-depolarize yung endocardium, and that's because the Purkinje fibers penetrate from the endocardium to the epicardium. So mauuna ang endocardium than the epicardial layer, okay? And if we compare between inferior and superior, so ito yung inferior, di ba? Ito yung lateral and superior. So mauuna dito kaysa sa superior lateral portion of the lateral and superior. Wag medial and superior. Because if we talk about medial and superior, nauna siya because that's the location of the interventricular septum. But if we talk about lateral and superior, I hope may anatomy na ba kayo? Siguro naman may anatomy na kayo, no? Naintindihan nyo yung mga lateral and superior. So bahala kayo dyan. So this will come out in your exam. There is that AV node delay and that the septal depolarization precedes lateral wall depolarization. Alam niyo ba, when I was in medicine, hindi ko alam yung meaning ng precede. Naloloka ako. Ano yung, during exam, septal depolarization precedes lateral wall depolarization. Hindi ko siya maintindihan ano nangyayari. So that's the common mistake of the students pag hindi mo ma-interpret yung word. Mahirapan ka. Ibig sabihin ng precede, mauuna siya. yung septal depolarization kaysa sa lateral depolarization. So, pwedeng pagpalitin lang siya, lateral depolarization precedes septal depolarization, magiging mistake na siya. So, ang sarap ilabas sa exam, no? So, you have to put your mind in the mind of the examiner para makapasa ka sa exam. Okay. Next, so the normal pacemaker, paulit-ulit is the AC node, and that's because it has a faster rate, 80 to 90 beats. 80 to 90 sabi niya eh, but for me, it's just 60 to 100. Hayaan mo na. AV node has lower rate, 60 beats daw, but for me, it's like 40 to 60 beats per minute. And if you look at the Purkinje fibers, mas lower pa siya, 15 to 40 beats per minute. The ventricular muscle has no pacemaker capacity, meaning it will not fire on a rhythmic manner. Pwede siyang mag-fire, kunwari na infarcted yung ventricular muscle, pwede siyang mag-produce ng electrical impulse, but that's an abnormal firing rate. It will cause ventricular fibrillation or tachycardia. It will kill the patient. All right? Kasi pag sinabi nating pacemaker, yung trying to make the person survive na beat, yung ventricular firing kasi, it will not make you survive. It will kill you. Anyway, ectopic pacemaker, any cell outside the SE node can be an ectopic pacemaker. For example, atrial cells, when it's infarcted or there is that scarring, it can fire, let's say, if the firing rate of the SE node is at 70 beats per minute and this atrial cell is now firing at 80 beats per minute, it will naturally override the SE node and it will become the pacemaker, but we call it ectopic pacemaker. And so it will produce a beat at 80 beats per minute, but without a P wave. So you will see this in atrial fibrillation, for example. It's an abnormal rhythm wherein the firing pacemaker is ectopic. It's coming from an infarcted atrial cells. Let's say if it's firing at 80 beats per minute and the AC node is firing at 60 beats per minute, when this atrial atrial cells that are infarcted will supersede, tama bang term? It will inhibit or it will override the AC node. So it will be firing at 80 beats per minute. Wala siyang P wave and there will be just QRST on the ECG but no P wave. So you will know that it's not a sinus rhythm but an atrial fibrillation. Okay, we will go to that in detail on the next lectures. So ito yung example how the brain can affect the automaticity of, not automaticity, but somehow affect the capability of the heart to beat on its own. It's through autonomic nervous system. So it can stimulate through the sympathetic activity and it can decrease the activity by parasympathetic stimulation. So pag sympathetic, fight and flight mechanism, so pa-increase ng heart rate, it will increase the velocity of the impulse conduction, so mas mabilis. And then increase the force of contraction of the ventricular muscles, mas stronger. That's inotropy. When we say increase heart rate, that's chronotropy. So these are just terminology. When we say chronotropic change, meaning we are changing the rate. And when we say inotropic activity, we mean a stronger contraction. And so the sympathetic stimulation, norepinephrine acts by increasing sodium and calcium permeability. So matagal pang chapter, sympathetic nerves uses norepinephrine on the postganglionic neurons anyway. So it's the sympathetic nerves that uses norepinephrine while the parasympathetic uses both acetylcholine and the pre and postganglionic neurons. Don't worry, it will not come out on this exam, but we will lecture that on the next chapter. So opposite yung effect ng parasympathetic stimulation to the heart, it will decrease the heart rate, increases the AV nodal delay. Don't be confused when we say increase the AV nodal delay, it will cause bradycardia. You decreased, let's say, more than 200 milliseconds, edi tatagal yung pag-contract ng ventricles. Again, acetylcholine, then AV node, moderate activity slows down impulse conduction. Basta opposite lang sa sympathetic stimulation. Yes, we're done with this topic. Any question while I will try